Hello and welcome to another McKnight's Thought Leadership webinar. You're tuned into Protecting the Skin Microbiome, Strategies to Manage Moisture and Prevent Pressure Injuries. I'm McKnight's Long-Term Care News Executive Editor, Jim Berkland, and I'm your moderator. This is what I call one of those well-grounded webinars. While so many presentations lately are concerned about what to do during or because of the pandemic, the principles and practices we're discussing today are certainly pertinent at any time, pandemic or not. We'll bring on our outstanding speaker in a moment, but first we have some housekeeping matters to take care of. Today's slides are available for download. You can click on the button right in the bottom there with the red circles and print them out at your leisure. If you are having any audio problems with this broadcast, please first check the volume control on your device, as this is the most common cause of hearing problems. Please note that the sound is coming from the computer speakers. You also have a help button in case your own troubleshooting doesn't work. We will have time for a Q&A segment near the end of the presentation. If you have any questions for our speaker, please feel free to type them out and submit them to us, starting now, in fact. Those that we don't get to in real time will be answered afterward. We'd also like to note that this program is made possible by support from Cardinal Health. Please visit the fine folks there at cardinalhealth.com. Finally, this session will be archived and available on demand shortly after this live broadcast. You can access it again, or others can experience it for the first time by simply going to the registration page to enter this studio. The URL is mcknights.com/052521 webinar. Don't worry, you'll see that on a slide at the very end. Now, I'd like you to meet our presenter. Cathy Milne is an advanced practice wound ostomy continence nurse with Connecticut Clinical Nursing Associates. She has provided care across the continuum in long-term care, acute care, home care, and outpatient settings. She also provides consulting to organizations wishing to improve wound outcomes, and she conducts clinical research. In addition, she lectures nationally and internationally. She is the co-editor of the text Wound Ostomy Continence Secrets and Wound Care Certification Study Guide. You know, Cathy, as I was preparing for today's webinar, it really struck me. Would it be fair to say that even industry veterans can use some reminders about some of these things you're going to talk about today, and they might not even realize it?
Sure, Jim. I think there are a lot of clinical pearls people are going to walk away from, and one of them is coming up pretty early in the presentation. And it's something that everybody can take back and show everybody else in their clinical setting.
Okay, well, you know, that's why we love these McKnight's webinars that way, and we're looking forward to it. So if you're ready to go, why don't you take it away?
Great. Thank you very much, Jim. I have some disclosures here, and I won't read them all and bore everybody, but welcome. I do want to thank you for taking the time today out of your busy, busy day. I know an hour is so, so precious, and I do appreciate you coming to listen to this webinar today. So we're going to talk about a different thing. We always hear about the gut microbiome, but you know, the skin is the largest organ and it has its own microbiome. So we're going to talk about what that is, what it's made of, and how we can optimize that. We do talk about what we do, what we think is really good care, but actually probably impacts the microbiome, and then eventually will impact the skin and discuss and have skin issues related to that imbalance. And we're going to talk about moisture management and how breathability in the products actually can help maintain a healthy skin microbiome. Additionally, we're going to talk about the difference between incontinence-associated dermatitis and pressure injury. So this is that little tease activity that I kind of alluded to Jim. So if you have a zip top bag next to you, maybe you're eating lunch, hopefully it's clean inside and you can wipe that peanut butter and jelly out, put your hand inside it, because this is really interesting. And you want to just kind of zip it up as close as you can, and you probably want to use your non-dominant hand so you can continue to write some notes down if you need to do that. So while your hand is sitting in that little plastic Ziploc bag, I'm going to talk about the role of the skin. So there's actually three distinct layers, and we all are very familiar with them: the subcutaneous or hypodermis, dermis, and epidermis. And the epidermis is really fascinating because it actually is several different cell layers. Even though they come from the same cell, they actually morph as they migrate upward. And so they start as those keratinocytes, and then as they mature, they actually change shape. They actually start to have a little function, and by the time they're at the top, they're filled with keratin. And keratin is actually will repel water and fluid, so that is very helpful in keeping our own moisture in place. But it also takes 120 days to get rid of that stratum corneum. So, for example, if you have somebody who's had a injury and it's a little discolored afterwards, and we see this a lot after an inflammatory response, such as you would see in candidiasis or incontinence-associated dermatitis, or even a healed pressure injury, is that you'll have this discoloration. That's called post-inflammatory hyperpigmentation. Well, that pigmentation is in the stratum corneum because those cells were injured as they were maturing up. So it will take almost 120 days for that pigmentation to go away. So, people panic that there's still some type of discoloration, but it's really nothing to be concerned about. So sometimes you just have to be patient, even though 120 days seems to be a lot. So that lipid layer is very important. So think about the skin, that epidermis and dermis, as like brick and mortar. So your brick are the cells, and the mortar is everything in between, and that's those lipid layers. So in that lipid layer, there are ceramides, there are cholesterol, free fatty acids, and one thing that we really don't talk a lot about are these natural moisturizing factors. And these are essentially humectants. So what a humectant does is to kind of seal in the moisture that is naturally there. And actually, you have different levels. So you have different amounts of humectants, of your natural moisturizing factors, more at the bottom, because obviously you have a lot of wet tissue under that. And as it gradually goes towards the surface, you have less and less. But when you really want to pay attention to what's in this lipid layer. So I have to think about the chemicals and the ingredients of all the things that we put on patients' skin. Are they replacing the lipid layer? Do they have ceramides in them? Do they have cholesterol in them? So your microbiome is really a community of microorganisms that live in a specific habitat. And it's very interesting. We have lots of different bacteria on us, and we also have fungus, and we have viruses, and we also have mites. And I think that makes us feel like creepy crawly. Now, the microorganisms actually will be different depending on where they are on the location of the body. So there was this great study back down in the 90s when somebody was looking at bathing patients, and they found that there are different microorganisms on the face as compared to the axilla, as compared to the abdomen, as compared to the perineal area, as compared to the feet. And that kind of makes sense that, you have different structures and different roles of those areas of the skin. So your bacteria and microbes are going to be a little bit different. But what the interesting thing about this study is that they found that they had, when you move those microbiomes around, and from, let's say, the axilla maybe down to the leg, if you haven't changed your bath water or haven't changed your washcloth, you actually can take bacteria that don't belong into that new area and can actually contribute to infection if everything else is set up right, such as you have a fissure or some type of open wound. So the microbiome is really very, very protective. And I think we've heard all about protection for the last year and a half and how we need to protect ourselves against pathogens. Well, our skin, which is our largest organ, does that. And so it does work synergistically. So at first, there are the bacteria that sits on top of your skin actually will kind of override the bad guys that set up there. And for the bad guys that end up getting into one of those little micro cracks, then your white blood cells actually invoke an immune response. And as we all now know about T cells and B cells over the last year and a half, we actually prime those T cells. So when a bad guy gets down there, the T cell says, okay, I've seen you before, and I really don't want you to, come in and ruin my living arrangement. So the next time you come in, I'm going to get somebody to engulf you now, a white blood cell count, or white blood cell. And then if you come back or bring more of you, I am going to fight you with a big, huge immune response. So we want our T cells, and that's why as we get older, we have a tendency not to be able to fight off these infections because our T cells are less numerous and they're less robust. Now, we're going to talk about pH in a little bit more detail, but your optimal skin pH is about 5.4, although it can range from 4 to 7. And it's really important in maintaining an intact skin barrier because it will kill off or reduce the ability of an invader just by modulating the pH. If they don't like the pH of the environment, they're not going to hang around very long. So we actually have two different types of glands here. We have epicrine glands, and we have apocrine glands, and they're a little bit different. So the eccrine glands actually are everywhere in your body, and they really are for thermoregulation. So if you get hot, you vasodilate, and you're able to release moisture through that. And actually, even if you're not somebody who sweats, you're losing anywhere between 500 and 700 milliliters per day. And the apocrine glands, they're the ones that are actually found in the axillary, inguinal, perineal, perianal areas, and they're actually associated with hair follicles. Now, there's a couple things about this. So the apocrine glands actually secrete, they're a little bit more alkaline, so they have a tendency to kill more bacteria, and you also have different kind of bacteria that line the hair follicles in that area as compared to the bacteria that sits in the sweat glands. Now, your skin microbiome can actually be different. It's different amongst all of us and different within us. So we do know that you have this acid mantle, so that your skin actually will secrete this sebum up through your sweat glands and coat the epidermis, right? So now what you have here is that as your skin pH becomes more alkaline, and that again, your age, starting at the age of 50, you start losing that ability to put out as much sebum. And you also have less ceramides within your lipid layer. And what you end up doing is, because you slowly change your pH to a higher pH, you get more bacteria there. Also, your gender influences pH. We do know that the skin hydration, the transepidermal water loss, and sebum is also is higher in men, and the pH in women are actually higher. Now, again, if you have a problem with a disease state such as atopic dermatitis, irritant contact dermatitis, and maybe a skin disorder such as eczema, that can also change everything too. So again, if you have a lifestyle issue, or not an issue, if you wash your hands every day in a chemical solution, let's say you work in a lab, that is going to impact everything. One of the interesting things about sweating, though, which I find very fascinating, is that your palms and your soles do not sweat when you're hot. They only will produce moisture when you are stressed. So here we talked about these eccrine glands and the apocrine glands. And the one thing that I do want to talk about is that they serve as a regenerative source, which means there are epidermal cells that line the lining of these glands and the hair follicles. So if you kind of shave off the top layer, so let's, in this picture, if you take those little veins, the red and blue blood vessels there, and just kind of cut the skin off there, your cells actually, since they line these hair follicles, will actually come up the hair shaft and then spread over and heal the wound. So you actually can use these glands to regenerate tissue. When we're talking about an imbalance of the microbiome, we're really talking about inflammation. So if we look at acne or atopic dermatitis, it's really hyperproliferation of cells that causes inflammation. And over on the right, if you're looking at somebody who has a diabetic foot ulcer with an infection or maybe a medical device related infection, these are the bacteria that kind of join together and make a biofilm. And we all make biofilm, and one of the things that you can see in your own body of biofilm is your teeth in the morning after you've slept for 6 to 8 hours. You get that film on your teeth. That's a biofilm. These bacteria just glob onto a surface and they start to multiply. And when they do that, they want to go from a colony to a city, and they do that to by protection. And they protect themselves by secreting this little slimy film. That's why your mouth feels so yucky in the morning. But also, so that's an inflammatory response, but it's chronic and low level. Now, in intertrigo and incontinence-associated dermatitis is also an inflammatory response. And we don't ever think of that as an inflammation. But when we look at this as an inflammatory disease, we actually start to treat our patients differently. So let's talk a little bit more about incontinence-associated dermatitis and how it impacts that microbiome. So first of all, the moisture will increase the humidity. And this is all a lot about the microclimate. And so we do know that the humidity will actually increase the temperature. And once you increase humidity, you'll also change the type of bacteria that are there. So the bad guys really like it a little bit more moist, and they start to proliferate. And the guys that try to prevent everybody from attacking the host actually don't like it hot and moist. And so they actually are become less available to overcome the bad guys. Now, occlusion, we know, is the inability to, what happens is you can't dissipate any heat or temperature or humidity that has built up in and around your skin. So that actually is bad. And how we occlude our patients all the time. We put on briefs, we put on pads, we put on, and a lot of our elderly patients are cold. So they also have incontinence. So they may have their brief, they may have a liner inside their brief. They'll have 1 or 2 pairs of underwear over that, and they'll wear the flannel shirt that goes all the way to their knees. So they have several layers, and all that does is increase the temperature. So once you have an increase in temperature, your blood flow increases and so does your sweat gland activity, which again then goes back to increasing, if especially in the perineal area, you have the glands which are putting out more and more alkaline pH. Once you also have increased temperature, you also have increased oxygen needs. And so if you have something that a patient, let's say the patient is sitting and they've compressed their vessels so they can't get their increased oxygen needs that they may need. Now, this is from a great study and looking at what happens when you have increased humidity on the skin. So we do know that you are more likely to have more fissures. You're going to lose more water from your lipid layer. But more importantly, you have this increase in this, what in the physics guys would say, increased frictional coefficient. So what that means is that are you slipping or are you kind of dragging? So a high coefficient actually is very slippery and a low coefficient actually allows you to kind of stick a little bit. So what happens when you have increased humidity, you have inflammation, you have changes in the microbiome, and you actually will increase your coefficient and then kind of stick to any surface that is there. So there's lots of sources of humidity, and although we typically think, oh, it's incontinence associated dermatitis, we've got sweat. Once we lose that lipid barrier, we're starting to have moisture of our own from inside our dermis leave. We also have the sources of our body worn and bed and chair products, as well as clothing and other textiles. So there's this microclimate, and that's really the conditions in that area, that little area of air between whatever your patient is in, whether that be a brief, an underpad, a liner, or their own clothing. And so that's the climate in that little airspace, and that gets a lot of attention. So, and speaking of attention, if you had that little plastic bag and now you looked in your at your hand, you would actually see the sweat and the humidity so you started to sweat, your temperature climbed, you actually vasodilated, you have increased humidity, and now you can actually see the humidity that is in that microclimate next to your skin. Now, this is the same thing that happens to our patients every time we put a body-worn product on them. So humidity really is liquid. And what happens when you have liquid is that the cells will either shrink or swell depending on the osmolality of that liquid. We have tendency to macerate. And then again, what happens is that it's very easy to break those cell apart. And before they break, they have inflammation. And we see inflammation as erythema, typically on skin. So here's that skin pH. We kind of already talked about that. So as you can see, the more basic or alkaline you are, the better you kind of are, and you want to be a little bit in between. You want to be a little bit acidic so that bacteria doesn't proliferate, and you can reduce the amount of yeast that are on your skin. And we have a tendency to have more yeast on our skin. A lot of our patients, one, because we've given them tons of antibiotics over their course of illnesses, so we have already changed a little bit of their microbiome. But in the acute phase of that antibiotic, we do see that most antibiotics are excreted. There will still be some left over in either sweat, in your urine, or in your stool. And if that contacts the skin, then you have just overflowed that microbiome with a ton of antibiotics, killing your normal bacteria and allowing that yeast to proliferate. So when you have that prolonged skin occlusion, again, you increase your humidity, change your pH, get that temperature growing, things start to grow like crazy, and that epithelial barrier breaks down. And really what happens is once your skin breaks down, that immune response triggers cytokines, which causes inflammation. So when your patient is saying, I itch, your staff say, gee, they've got some redness there, you're already too late. You already have a problem. So I do infrared thermography also, and I did this so before and after I put my hand in the plastic bag. So you can see up at the top, my hands are equal pretty much in heat. And in the lower left-hand corner, I am comparing my hand in a plastic bag versus just a paper towel. Because remember, a paper towel is pretty breathable, right? So if you look at this, then you see on the left, I have a lot more heat on my plastic bag than I do if I have a paper towel, because I'm able to dissipate the humidity. I don't have that increase in temperature. We do have a great little chart. It's kind of boring, but it really tells you a lot about the pathophysiology of incontinence-associated dermatitis. And we do know that urine is bad, and we know that feces is bad, and actually the type of feces is bad because there's actually 7 types of stool, type 1 being like small hard rabbit pellets, which means your patient really needs to be hydrated, versus type 7, which is at the other end of that spectrum, which is completely liquid. So as you go to type 5, 6, and 7, the pH of your feces actually rises. And when you have both urine and feces together, you will see that the pH of the feces will actually change the urea in the urine to ammonia. And I think if any of us on the webinar today have washed windows with ammonia, you know how caustic it can be. So that adds again to destroying that lipid barrier and causing an even greater inflammatory response. So when you see that, you end up having that whole cycle of the skin barrier breaking down, bacterial overgrowth, cutaneous infection, and then again, by the time we recognize incontinence-associated dermatitis, the inflammatory process is way out of control. And we do see sometimes blisters that are there, but invariably they're always there. They just happen so quickly we hardly see it. Now, we do know that pressure injuries are everywhere, and we do know that IAD and incontinence-associated dermatitis, moisture, are really one of the key factors in the development of pressure injuries. Now, once you add the extrinsic factors of friction and shear, a good way to determine the difference between shear and pressure is to make a fist. So everybody make a fist. Okay, good. Put your knuckles straight down on your desk that's in front of you, and that's pressure, so it hurts a little bit. Now move your fist back and forth. So that hurts more. That's shear, because you're actually taking those different tissue layers and moving them apart. So if you have tissue that's wet, macerated, the cells are swollen, when you move that wrist or your back and forth, your hand, you're going to actually have more damage because there's no integrity left because the cells are so swollen with moisture. So they just kind of fall apart. So this is all about pressure injuries, are all about cell deformation. And when the cells deform, there is ischemia and then cell death. So what we really want to do is focus on trying to prevent the humidity and prevent temperature increases. Because when you end up having the pressure and shear externally applied, you actually will get a pressure injury. And this is really, we see this typically more profoundly in a device-related pressure ulcer. So there is a difference between the pressure injury microbiome and the IAD microbiome, and that's because once you have the destruction of the dermis, then there is actually within 20 hours there is a biofilm set up in that pressure injury, where you don't see that as frequently in the incontinence-associated dermatitis microbiome. This is a typical patient with incontinence-associated dermatitis, and I apologize to those who are eating lunch or another meal. And pressure injury. So you can see the difference. Associated continence, IAD, very superficial, irregular. They usually are not weepy until there is deeper dermal destruction. You will also see that it is usually just the perianal area. And you can see here these little dots. That actually tells us that there's probably a fungal component. And down by the posterior thighs, you can see those dots that are still intact, which really tell us that the microbiome has been shifted more towards a fungal area involvement. Whereas the pressure injury, very round, almost always over the bone, and they aren't nearly as angry, because pressure injuries are usually very chronically inflamed, so you have a lower level of inflammation as compared to incontinence-associated dermatitis. But you can also have mixed etiology, and this is where I find in when people do an admission assessment that they have a tendency to put things in one box. It's either pressure or it's incontinence-associated dermatitis. So if there's any clinical takeaways today, one is to look at your electronic medical record system to make sure you can actually put more than one type of etiology in there, and to teach people that you can have more than one thing happening in the area at the same time. So we do know that besides incontinence, we have a lot of other risk factors, and that includes patients who are have compromised mobility, they have pain, they have fevers, they are on immunosuppressant therapy, they're very, very sick, but also the use of occlusive incontinence containment devices also contribute to altering that microbiome. This is a great chart to actually bring to, you can hang it up in your utility rooms. This is available from the Ghent Global IAD categorization tool. So it helps people determine the severity of incontinence-associated dermatitis and if there is a subsequent and concomitant infection. So you can go to their website, download it. It's great. People look at it all the time, and it actually helps the staff determine the difference between IAD and non-IAD. So essentially, we would do the management is really looking at that skin and really looking and thinking, what is causing this erythema? Is it brighter or darker than usual skin tone? Are there signs of inflammation? Did things blanch? When you clean the skin, you want to use something that's pH balanced and that may encourage an slightly acidic pH. So you want to know the pH of your products. You have to teach people not to rub. People just want to rub everything, right? And you really just want to wet and pat, wet and pat. And then you really want to be proactive in your skin. So you want to replace those ceramides. So you're going to want to replace those natural moisturizing factors. So look at things that have silicone in them. Sprays are available. Petrolatum, which is Vaseline, which is a trade name. Zinc oxide creams. There are some newer things out. They are cyanoacrylates. That they're either sprays, they're pads. And there's some other devices out there. But you want, if you have damaged skin, you want to wick all that moisture away because, again, that is wetness, humidity, and you're going to get more bacteria. And you also want to prevent traumatic injury in the area by not having traumatic tapes in that area. So here's a great little thing that we use to help people think about how to manage that skin microbiome. If they have a normal skin, they're not showing any signs of inflammation. Clean, moisturize, protect. But once they start being incontinent, you really should be thinking about really examining their toileting regimen and then using, again, clean, moisturize, protect. You might want to need an antifungal. We are seeing some resistance to miconazole in areas of the country, so you may have to go to a nystatin product. And then if you're eroded, you're going to most likely have to think about using a acrylate-based products and perhaps a different kind of containment, effluent containment device, and really think about using something different for your barrier or your brief. So the interesting thing about when you're looking at that last little algorithm, there's a missing link here. And the missing link is nobody has said in any of those clinical practice guidelines, you better look at the type of incontinence product you're using. There is, so when you start looking at incontinence products, they are very, very complex. And unless you do the deep dive, you really don't appreciate what goes into them. So they typically have a skin contact layer, and that's the one that's right next to the patient. And then they have, and so the fluid needs and effluent needs to move through that quickly. And then you have this acquisition transport layer. So that helps move things soon or through faster. And then you need to store it, right? So they have a storage core, and those are usually super absorbent polymers, or they're cellulose fluff pulp, or a mixture between the two. And that makes a huge difference, because if you're just fluff pulp, you're not, things are going to go back onto the patient because it's really not retaining and holding on and trapping that fluid. Then you have the containment layer, because obviously if your storage layer gets overwhelmed, it's going to continue out the other side. And so we usually see a plastic film. Now, plastic films in and of itself are a whole interesting science. You have those that are occlusive and those that are breathable. And those that are breathable have a tremendous advantage because they can actually lower your humidity. They can lower your temperature. It improves your microclimate, and you're going to get your skin back to a more normal pH and drier environment. And then after the containment layer, there's usually something else, a tactile surface layer. Some products have it, some places don't. So just so it makes the patient feel like they have some type of dignity, because then it doesn't crinkle and crunch and make a lot of noise when they move. So every product will, have some type of absorbent core. But again, what's it made of? And what's that back sheet made of? So these are the things you're going to really want to ask your vendors of your briefs and underpads, because it makes a huge difference. So the top sheet, you want something that's going to rapidly pass that urine through. Now, we do know that sometimes zinc and other protective ointments and thicker creams can actually clog these holes. And so your urine, even though your product may be great, your barrier may be preventing that urine from going into those holes and through the uptake. So you're going to want to ask if the vendor has any data with regard to that. So they may or may not, and a lot of it is because there are probably 6,000 different creams out there, and there are a variety of different briefs and underpads, and nobody has done the complete research looking at all combinations yet. So this absorbent core, if it's going to work, it really should have superabsorbent polymers. So what you see, that picture, is the cellulose fluff. And when you use cellulose fluff and it gets wet, it bunches up, it leaves it's where it's supposed to be and goes where gravity goes. And again, if you would squeeze that cellulose fluff, any effluent that's in there will actually come back out. Now, those superabsorbent polymers, we're seeing them in baby diapers. They absorb lots of fluid, and 20 to 50 times its weight in salt-containing fluids such as urine. So the thing is about the superabsorbent, you have to make sure it doesn't move within the pad, because if it does, then that is not helpful for the patient. So breathability is really, really important. So you can have air permeable and moisture vapor permeable. So just because a brief is breathable, you should be, again, asking, is it air permeable or moisture vapor permeable? So air permeable is when air is passing through the material, and you can actually lower the temperature. Now, moisture vapor, when it can also pass through, and that's really a key factor here, because as you saw putting your hand in that plastic bag, if it's not moisture vapor permeable, it's going to increase your humidity, and then you're going to get that increase of temperature, and then everything kind of goes downward from there. So you really want to know if your product is breathable, how breathable is it, and if it's not non-rebreathable, the question I think we all have to ask is, why are you using that? Because we know the physiology says that it's bad for our patients. Breathability really matters, and I think a lot of people think that we just want to contain things from getting on the sheets, but we really want to allow that water vapor to pass. And here's a great example of water vapor passing through a breathable product. And this product is the Cardinal product. So there are breathable zones in the briefs. So now NAFC, if people don't know what NAFC is, it is the National Association for Continence. They're an independent group, and they actually have done a lot of research and have come up with standards for briefs. And they have standards that everybody should have a wing zone, and you can see where that wing zone is on the side, should be air permeable. And zone 2 is they don't have any standards, but they're saying that, some products are air permeable and some are moisture vapor permeable, and some are both. And zone 3, that's the core. That's where everything is accumulating, we hope. And that most of the products out there are rarely breathable, and some will provide a moisture vapor permeable area in this zone. And clearly, this is where we should be concentrating, because this is, if you don't breathe here, this is where you're going to get an inflammatory response. So, and how do we, measure this? We can measure this through these instruments that will measure evaporation, and then also those that conduct electrical impulses through wetness. And they do find a difference between the breathable and non-breathable diapers. And those research studies were done on the adult forum and on child models. And again, we do know that once you have a breathable form of a brief, that you're going to reduce temperature, humidity, and pH, and that they did do studies on vulvar skin as compared to the non-breathable products. And then we also know, and this is, this kind of explains it all, is that we know that breathable brief materials reduce the survival of yeast by 2/3. So if you're thinking, I'm spending a ton of money on antifungals in my organization, maybe it's not that you're having a problem spending too much money on your antifungals, you're probably not spending enough vigilance in terms of looking at how breathable your briefs are. So everybody always gets snagged on this. About, how many layers can you put on a low air loss bed without impacting heat or evaporation? So there was a study looking at that. So actually, it took 9 layers of material to prevent or to make it as like a non-low air loss bed. And of course, if you have a plastic backed underpad, that reduced things quite some bit. So because it interfered with heat withdrawal as well as the evaporation, and again, your increased transepidermal water loss and heat, humidity just doesn't go anywhere when you have that plastic. So you really want a non-plastic back pad. So you can use more than 1 layer, and you can use a sheet on these low air loss beds. The question is how much. So when somebody makes a draw sheet and it's really 8 layers after they finish it, then it's going to impact what else you put else on that bed. So here are all these standards from NAFC and what they look for. And here are recommendations for product performance. Please look these up. They're available from NAFC. So when you're thinking about buying a brief or a incontinence pad, this is this independent organization that allows this. And again, we're hoping that they will change to have and endorse breathable zones in that core area. So we have a lot of other considerations when you think about putting on an incontinence product, including, do they have fragrances? Are they, do they have textiles, dyes in there the patient might be allergic to? What are they? Do they have preservatives such as formaldehyde? Because all those things can impact and cause an irritant dermatitis. So really, when you're selecting an appropriate product for use, you should be looking at something with the right absorbency level, and because they all are different, and the skin sensitivity, your size and fit, I think is the most important. But to me, you really want something breathable, because why would you want to kind of knowingly put something on a patient that may alter their skin microbiome and eventually cause them a skin issue? I do want to talk about the Cardinal product, because they do have breathability, and you want to think about their zone 1, which everybody's got, the air permeable, but zone 2, which is moisture vapor permeable, and also on zone 3, we have some breathability there. And I'm sure you can contact your rep. Again, here are these characteristics of that ideal product. Again, you want to be cost effective, and being cost effective means not damaging the skin to start with. So Cardinal's product is truly breathable, and you should really consider calling them and asking them all these tough questions, because I think they'll be able to come through for you. And also think about what our patients are doing across the continuum. They may be leaving when they get to us, they may be incontinent. We'll be using underpads. They may be then being placed on a continence program, but still need briefs for this period, and eventually may be going home with underwear. So you want a product that is breathable across the continuum, and Cardinal does have many of these available, so your patient can go from one setting to another, or as they rehab and become from incontinent to continent or occasionally incontinent, they'll be breathable all the time. So this Breathe Easy technology promotes this optimal microbiome to keep that skin at that healthy level. Again, if you can breathe, it's better off. Your skin is cooler, drier, there's no humidity, and the bacteria that's supposed to be there stays there, and the bad guys don't proliferate. Here are a bunch of resources that you can look up. Here's that Ghent Global IAD category tool, your NAFC performance standards, and then how to choose the body-worn absorbent product for an adult with incontinence, because there are so many different variables out there. I want to thank you so much for coming today. And Jim, I really am looking forward to hearing some of the questions that may have come in.
Well, yes, I got to tell you, Cathy, outstanding job. Just some fantastic information. And as I told you folks, we really got it from a great expert on here. Going to get Cathy a chance to catch her breath for a second, but also remind you that you can ask questions and tap them out, and we'll see them on our end, and we can get them to Cathy. So that said, Cathy, I'm going to go right to Gaston has one. Put in an early question. I think you can answer this one straightforward. What is the conceptual difference between microbiome and microbiota?
So the microbiota is really of a particular site. And the microbiome, it's really almost semantics. Microbiome is a general term of what should be there and what is there. So your microbiota is more specific to what should be there and at what location.
Okay, very good. Now, Samantha writes in, does NAFC have thresholds for breathability in the core zone?
Unfortunately, they do not. NAFC recommends that the wings on the briefs be tested, but they haven't really looked at the cores. And because really Cardinal's the first folks out on the market with this breathable technology, there really hasn't been any discussion yet, because there's really only one manufacturer who does this. So they're not changing the zones to be tested yet. However, that being said, because this is novel and it is actually healthier for the patient, I think as nursing and healthcare professionals, we should be asking NAFC to start looking at this as a standard.
All right, very good. Colleen writes in, is there a difference for nighttime product that allows a resident to sleep without frequent waking by staff?
Yes. And it's all about how much effluent can be taken up and wicked away from the incontinent patient. So again, something with a super absorbent polymer, forget the fluff, the cellulose fluff, because you need it to be wicked away. So on our slide deck, we actually had one of the slides, and I'll have to move back here a little bit to see which one it is. So slide 50 actually has a little bar at the bottom. So it basically tells you how many cc's of fluid that the product can hold. So a lot of people are reluctant to go to have daytime briefs and nighttime briefs, only because they especially in some long-term care organizations, the aides get confused, and so they'll put a nighttime on during the daytime. And additionally, you'll find that people like to use the night times all the time, especially if they want to go to an activity or be out of bed longer. So it kind of, since it absorbs more, you can kind of have your patient out, not toileted as often. I don't think that's a really good idea. I do think that we should be encouraging continence and doing good skin health during the day when people are awake, and not using a nighttime product for daytime for convenience. But yes, you should be looking at those products that actually hold more. And actually that article from the WOCN talks about when you should be using the characteristics of the nighttime products versus the daytime products.
Okay, very good. Let's see if we can get to one or two more here before we have to wind down. Jackie writes in, if a product is breathable, does that mean the resident will have condensation or moisture on their pants or bed linens?
So the question is, so breathable means you're allowing the moisture vapor to leave that area that's sitting between the humidity, so to speak, through the brief and out to the air. So it's vapor, so it's not wetness. And that's a huge difference. So think about, vapor is like the bathroom mirror after a hot shower, and it gets all fogged up, but it doesn't really, you don't see it or feel it, and you don't really feel the moisture unless, because it disappears right away. It's almost, the other thing is moisture vapors, like when it's really cold out, when you take a, breathe out, it disappears right away. And that's what you're seeing with breathable products. It just disappears right away.
Okay, great. Let's go to one more, and then we can get some final thoughts, which I would encourage everyone to hang around for sure. Ginger writes, what do you recommend for highly incontinent residents that may need double layering of incontinence products?
Okay, so anytime you put two or double layering, you're increasing heat, humidity, temperature, and then you are upsetting that microbiome. So what you really should be thinking about is the briefs and the pull-ups that that you're buying. Look at those properties that you have. Is it the right size? Is it the right fit? Is it the right level of absorption? And should you be using a brief versus a pull-up? So there are a lot of things to look at, and I think one of the problems that I see when I consult in organizations is that everybody has it's one size fits all. And there's so many variety of needs. Like, we all don't drive the same car in the audience, right? So we all shouldn't have the same type of brief because we all have different needs. So we really should be stocking a range of both absorbability and sizes and types of products.
Excellent advice. Now, to our final step here, I warned you this would come. We've gone through, you've had 57 minutes of great advice. Now, what is the one thing you think listeners must leave this webinar with?
I think people should realize that the skin microbiome is totally unappreciated, and how we think we manage incontinence is really for our own convenience, and actually is probably causes more disruption to that microbiome and potentially can eventually harm a patient in the long run. I think what we should be doing is really looking at the products that we use on our patient's skin in that area, and anything we can do to promote a healthy microbiome is paramount to good patient care.
Well, outstanding. We'd expect nothing less after all of this. Some great advice. I hope you've enjoyed this webinar as much as I have. This session will be available shortly at mcknights.com/052521 webinar. See it there on your screen. And we'd like to give our special thanks to Cathy Milne for some outstanding information on resident care today. And we also want to thank our session sponsor, Cardinal Health. Visit it at cardinalhealth.com. And of course, we want to thank you, our listeners. You've been a big part of the success today. Some really excellent questions. We look forward to seeing you again at future McKnights webinars. You can keep track of what's coming under the events tab at mcknights.com. Just look under the webinars subtab. Once again, thank you for tuning in. This is Jim Berkland from McKnights, wishing you excellent health and outstanding days ahead.